Hello, everybody, and welcome to the Guthy-Jackson Charitable Foundation Education Center and the NMOSD Grand Rounds series. We welcome all in attendance and remind that the Guthy-Jackson Charitable Foundation is proud to be a source of information about NMO and related conditions. The content of the following presentation is based entirely on published data and expert opinion. GJCF is not a clinical provider. It does not offer or represent diagnostic, therapeutic, or clinical care recommendation or advice on personal health. All patients and caregivers are advised to consult with their healthcare team for specific information. The NMOSD Grand Rounds series has several overarching goals. First, to provide a practical summary of latest information on a specific topic. The series is designed to emphasize key themes and clinical pearls, and it is intentionally inclusive of non-specialist audiences. There's a pocket guide at the conclusion of the presentation that highlights key points as a reference. We'd like to remind everybody that there is continuing medical education activity opportunity for this presentation. To do so, please visit the GJCF Education Center using the QR code shown here. Once there, select the session you'd like to view and register for that session to view it and fulfill the CME credits. Then receive the CME certification online. My name is Michael Yeaman, and I'm happy to moderate the presentation today. I'm an advisor for the Guthy-Jackson Charitable Foundation. And we are delighted today to have Dr. John Chen speak with us today about evaluating and optimizing patient visual health in NMOSD. Dr. Chen is professor of ophthalmology and neurology and the director of the Neuro-Ophthalmology Fellowship Program at the Mayo Clinic. John, thank you so much for your effort and all the work you've done in NMOSD, and we look forward to your presentation.
Well, thank you so much, Michael. I'm very excited to be here and talk about how NMO can affect the vision and what we can do to optimize visual health in our patients. I'm a consultant to UCB, but won't have any relevance to this talk. So I thought I would just talk as a background about optic neuritis. And optic neuritis is the inflammation of the optic nerve. And it's the way that conditions like NMOSD, multiple sclerosis, and another entity called MOG antibody-associated disease, it's through optic neuritis that it causes vision loss. And optic neuritis is actually the most common cause of optic neuropathy in young patients, but it can affect any age. Typically with optic neuritis, the vision loss tends to worsen over several days. And another clue to say that this is an optic neuritis is that 90% of patients have pain in the eyes, especially worse with eye movements. And so that can help differentiate it from other causes of optic neuropathy, like ischemic optic neuropathy, a stroke to the nerve, that can cause vision loss as well, but it tends to be painless. Whereas optic neuritis is inflammation, and therefore there tends to be pain. And so this subacute worsening of vision loss over several days associated with pain with eye movements, optic neuritis has to be very, very high on your differential diagnosis. And then this is a patient with optic neuritis, and you can see here on MRI, we tend to see enhancement of the optic nerve, confirming the optic neuritis attack. For typical optic neuritis, 90% of patients improve to 20/40 or better, which is quite good vision. That's what allows you to drive. But for NMO, unfortunately, the outcomes tend to be much worse in terms of the vision, even after the optic neuritis attack. So when it comes to optic neuritis, we typically think about three main diseases: multiple sclerosis, NMOSD, where we've got the biomarker aquaporin 4 antibodies, and then MOG antibody-associated disease, or MOGAD, where we have MOG antibodies as the biomarker. The most common cause of optic neuritis in the United States is multiple sclerosis. And so that's kind of what we think about as our typical optic neuritis. And it tends to recover, and only 3% of patients with MS optic neuritis end up 2200 or worse. And that's an important number because 2200 means you're legally blind. And then 20/40 is also an important number because that's your ability to drive without any restrictions. And with MS, you can see here that 92% of patients end up recovering to 20/40 or better. And so multiple sclerosis can cause a good amount of vision loss with optic neuritis, especially at nadir, but the majority of patients tend to recover. We compare that to NMO, and I thought I would just kind of highlight a case that we saw in clinic of NMO optic neuritis. This is a 36-year-old African-American female who previously had a history of optic neuritis in the right eye. And you can see here that it left the optic nerve with a lot of pallor. The nerve's pretty pale, evidence of the prior optic neuritis attack. And her vision did not recover back to 20/20 or 20/40. In fact, she remained count fingers. So even worse than 2200. All she could do was count fingers and couldn't read any of the letters on the chart. And now she's coming in with an optic neuritis in the left eye with a visual acuity of 2400. So again, this legally blind kind of vision loss. And on exam, what we see here, not surprisingly, is that we're seeing inflammation along the optic nerve of that left optic nerve. And this enhancement of the nerve kind of extends down a good portion of the nerve, and that's pretty common with NMO, where it tends to cause pretty long segments of optic neuritis, whereas MS, it tends to cause enhancement of the optic nerve, but shorter segments, and it tends to cause less vision loss when it's MS. And then we do a MRI of the brain, a T2 flare looking for lesions suggestive of multiple sclerosis, and we don't see any. Again, this is pretty classic for NMO, where you get this profound enhancement and inflammation of the optic nerve, but no brain lesions, at least your typical MS brain lesions. And of course, you can get inflammation of the spinal cord, which can cause a lot of disability that way. So in terms of optic neuritis from NMO, unlike MS, where only 3% of patients end up 2200 or worse at legally blind vision, over a third of optic neuritis from NMO can end up 2200 or worse. So this is a blinding condition. And only 40% of patients end up 20/40 or better. So these NMO attacks from causing optic neuritis are very, very severe, very, very blinding. And that's why we treat these patients so aggressively with IV steroids, plasma exchange. We're trying to prevent them from being legally blind. And that means aggressive treatment, which also means very acute diagnosis, early diagnosis of these conditions. It has to be on the differential diagnosis, especially for any severe optic neuritis. And we're going to step through ways of making that diagnosis in just a little bit. Before we talk more about diagnosis of optic neuritis, thought we would talk about the third cause of optic neuritis, MOG antibody-associated disease, or MOGAD. And for these patients, they present similarly in that they often present with very severe vision loss, like NMO, but they tend to have more tendency toward bilateral optic neuritis than even NMO. If you've got bilateral optic neuritis, MOG has to be pretty high in the differential diagnosis, and then NMO, and then MS very rarely causes bilateral optic neuritis. About 50% of optic neuritis in MOG is bilateral. About 20% of optic neuritis in NMO is bilateral simultaneous. And for MS, it's probably only about 3%. Another striking feature of MOG optic neuritis is they tend to have a lot of disc edema. This is a patient that we saw where you can see bilateral, pretty significant swelling of the optic nerves. And with NMO and MS, you don't tend to see as much disc edema. And so this is a feature you want to look for in your patients with optic neuritis. If you see a lot of disc edema, you might be leaning more toward this being MOGAD and not MS or NMO. MOG tends to cause pretty profound vision loss at nadir or at onset. You can see this patient could only count fingers. And so that's a pretty classic feature of MOGAD. But fortunately, with treatments, especially steroids, it tends to recover much better than NMO. And on MRI, we tend to see pretty profound enhancement of the optic nerve in MOGAD. Similar to NMO, we see kind of these long segments of enhancement. But with MOG, it tends to not only involve the optic nerve, but the inflammation spills into the orbital fat, which we call perineural enhancement. So if we see this significant enhancement of the optic nerve with enhancement of the periorbital fat, then MOG has to go much higher on the differential diagnosis. So those are classic ways that MOG presents. Again, even though that MOG presents with very severe vision loss, very similar to NMO, they tend to recover much better. Only 5% of patients end up 2200 worse from MOG optic neuritis compared to that 33% with NMO. So the outcomes are actually very similar to MS. 91% of patients end up 2040 or better, very similar to what we see with MS. Again, much worse than NMO. And so these are these are our three main causes of optic neuritis that we have to think about. Again, NMO and MOG are going to present with very severe vision loss, but MOG tends to recover much better. Both NMO and MOG can cause bilateral optic neuritis. MOG even more commonly bilateral than NMO. MOG tends to cause more optic disc edema than NMO and MS. On MRI, both NMO and MOG are going to cause a lot of enhancement of the optic nerve, but MOG even more so where it spills into orbital fat. And unfortunately, MOG tends to recover better with steroids. And again, that's why NMO, we have to be so aggressive with our treatments. I'd like to talk about next how we approach optic neuritis in terms of our testing. I think one of the most common things we test is visual acuity. That's sort of like our blood pressure or our heart rate. When you go and see a primary care doctor, you're never going to see an eye doctor and not get a visual acuity. And that's how we test to see how well they can see in the center. And we've all heard 20/20, we've all heard 2200, but what does that exactly mean? And so I thought I would actually step through and kind of explain what we mean by these numbers. Essentially, what 20/20 means is that's normal vision. And what that means is that if you're standing at 20 feet, you're seeing what a normal person would see at 20 feet. And so on the chart here, this is your 20/20 line. And so if you're 20/10, that means you're actually better than what a normal person sees. That means at 20 feet, you're seeing what a normal person sees at 10 feet. And then here at the top of the chart, there's your 2200 vision. That's your legally blind. And what that means is a normal person is able to see this big E at 200 feet. But if you've had optic neuritis and you're 2200, you're sitting at 20 feet and you can just make out that E, but you can't make out these other letters. And so that's essentially what 20/20 means and 2200. Essentially, it's the bigger number at the bottom that is the worst. So essentially, 20/20 is normal, 2200 is legally blind, 21,000 is even worse than 2200. And so that's what we mean by these numbers. Another very important test that we do is the pupil exam. And what we do is the swing flashlight test, where we swing the flashlight back between the eyes about 2 seconds per eye. And what we're looking for is something called a relative afferent pupillary defect, RAPD. This is an objective measure of the afferent light input from one eye compared to the other. And if we do see an RAPD, it means there's asymmetric optic nerve or retinal disease. What's wonderful about this is it's 100% objective. It's normal in functional vision loss. It's actually normal for other causes of vision loss like cataract, glasses, or some kind of opacity like a vitreous hemorrhage. But what's great is it's purely objective. Visual acuity is important. We get that every time a patient comes in, but a patient could always say they're only able to see the top letter in their 2200, even though they can actually truly see the 20/20 line. And so a patient could have what's called functional vision loss, where, again, they claiming to be 2200, even though the optic nerve is normal. If they're truly 2200, they should have a relative afferent pupillary defect. And therefore, this RAPD is nice because it should be really present in every optic neuritis if there's vision loss, unless it's bilateral symmetric. Because again, this is relative kind of swing back and forth that they both have optic neuritis equally damaging both eyes. There will not be a relative afferent pupillary defect. But if you have optic neuritis in one eye with significant vision loss, there has to be an RAPD if there's true damage and vision loss. And so what I thought I'd like to do is show you a movie of a relevant afferent pupillary defect. And so this is us showing the flashlight in the right eye, and you can see it constricts. And we flash it in the left eye, and it constricts as well. So if you do the pupil exam this way, you would actually not realize that the right eye doesn't respond as well. What we're doing now is the swing flashlight test, and you can see when we swing it over to the right, the pupillary dilates. So there is a relative afferent pupillary defect there. All right, and so now what we can do is we can actually quantify the relative afferent pupillary defect with a filter in front of the good eye, which is the left eye. And when we put this filter in front of the eye, what you'll notice is that the pupil constriction now is equalized. And so we can quantify it. This happened to be a 0.9 log filter, a neutral density filter that we're putting in front of that left eye to equalize the pupil constriction. And so this swing flashlight test is, again, very, very important in confirming optic neuritis with vision loss, because if there's vision loss in one eye and the other eye is normal, there has to be an RAPD if it's from optic neuritis. And so it's one of our very important tools that we do in the neuro-ophthalmology clinic. Another test that we do is to check the visual fields. A patient could theoretically be 20/20 perfect vision in the center, but be missing a lot of peripheral vision loss from an optic neuritis. And that's why we checked with the visual fields. And the most common visual field you'll encounter is something called the Humphrey automated visual field. And what this does is it checks the central 24 degrees. That's the most common test it does. This does have the ability to check 30 degrees, 6 degrees, or 10 degrees, but the most common test you'll see is 24-2, which means we're checking the central 24 degrees. And what's nice about this tool is it has reliability indices. We can map out the blind spot, and it's quite reproducible, and it's very automated and very sensitive in picking up visual field defects from optic neuritis. And here's just a video of what the patient actually sees. And what you can see here is that at first the patient will have their chin here and they're going to have a flashing light in the center. And so what that's doing is checking the central foveal sensity, the sensity of your fovea, the center of your vision. And then there's going to be some flashing lights in the periphery. And essentially the patient has to click the button every time they see a flash. And that's how they map out the visual field. And their job, the patient's job, is to stare right at the center. So they're not looking at the dots, they're just looking at the dots with the peripheral vision. And again, it can be mapped out this way. This is a video from Dr. Bhatti, one of the prior neuro-ophthalmologists at the Mayo Clinic. But I think this is a really nice video, kind of shows what the patient sees. And visual field defects from optic neuritis are very, very common. In fact, we expect them. And the most common visual field defect is diffuse depression, and it can be mild, like this top image here is just very mild diffuse depression, or it can be more severe, or it can be absolute darkness. But you can see any pattern of visual field loss. These are actually visual fields seen in the optic neuritis treatment trial, where it was a clinical trial that was completed in the late 80s, early 90s, where they recruited over 400 patients with optic neuritis to look at risk of multiple sclerosis and whether steroids improved outcomes. And you can see here that pretty much every visual field defect was seen, including arcuate defects, altitudinal defects, hemianopias, peripheral vision loss. Pretty much anything can happen. But I would say the most common is kind of this diffuse depression or this central secocentral scotomas are the kind of the more common ones. Another thing that's important to do when you see a patient with visual field loss is to look at the reliability indices. What the test does is, again, it checks your peripheral vision, but it also kind of spot checks a couple of things. One thing that it does is it checks for false negatives. And what it does is it'll check to see if you click before on a button, a light, and if you click, yes, I saw that light, it'll actually go back to that same spot and actually do a brighter signal there. And if you don't click there, that's a false negative because you had clicked in the past saying you could see the light. And now they're checking that same spot that's brighter and you're not clicking. That means you're just not paying attention. And you can see here, this patient has a lot of field loss, looks pretty scary. But when you look here, they have a false negative rate of 53%. And this is actually a pretty classic cloverleaf field, which we see in patients often with functional vision loss. And the reason why we get this cloverleaf field in these functional patients is the testing algorithm tends to check these 4 spots initially and then check the rest. So this is a patient who, the algorithm checked these spots, they're clicking for maybe 30 seconds and then they just stop clicking the button. So this patient probably has functional vision loss. And this is the patient where you're going to check for a relative afferent pupillary defect. If this is a real visual field loss, and you can see the left eye is normal, there should be a large relative afferent pupillary defect. If there's no RAPD, then this is essentially 100% functional, at least the field losses. Because RAPD is actually proportional to your visual field loss, not necessarily visual acuity loss, but actually your visual field loss. And so the pupil exam for this patient will be very important because I don't trust this being a reliable visual field. Another way we can check visual fields is the Goldmann manual kinetic visual field. The benefit of this is it actually checks the full 150 degrees of vision, where with our standard automated Humphrey visual field, we're typically just checking the central 24 degrees. This allows us to check all the way out to 80 to 90 degrees temporally, here 60 to 70 degrees nasally. And how this works is it's not automated. You have actually a perimetrist who's talking with the patient, and they'll bring a light in from the sides. And when the patient sees it, they're going to say, I see it, or they're going to make some noise, and then they'll put a dot. And then they'll bring a light from this direction in, and then once the patient sees, the patient will make a noise and they'll put a dot. And essentially they can map out islands that the patient can see. And this is just an example of a normal Goldmann visual field. Everyone has a blind spot where the optic nerve is, but otherwise this is a normal visual field. Another test that we often do for our patients is color vision testing. And that's because optic neuritis tends to knock out the color pretty quickly, sometimes even much more so than the visual acuity. And the most common test that you're going to see in the clinic is the Ishihara color plates. And essentially, this is a bunch of circles where numbers are going to be in there that are different colors. And if you're not colorblind or if you haven't had optic neuritis, you'll see that this plate right here is a 74. And so patients go through about 14 of these to kind of see how much the color is influenced. With more accuracy, you can map out the color vision with the Farnsworth panel D15, where essentially the patient has to put these various colors in order. And if you've had optic neuritis, if you're colorblind, you can't put in order because they all kind of look the same. And if you really want to have very high detailed color vision, you can do the Farnsworth Munsell 100 hue, where you actually put 100 of these colors in order. Again, much more time consuming. So in the clinic, we typically use the Ishihara color plate. It's a very quick way of screening the color vision. Another one you might see in clinic is the HRR color plate, but they're both good screening tools for deficits in color vision that we often see with optic neuritis. Another tool that is very important is optical coherence tomography, OCT. OCT is sort of like an ultrasound, but instead of using sound, it uses light, and that allows for micrometer resolution. We get an OCT on pretty much every patient with unexplained vision loss, and the amount of detail we can get from these images is really phenomenal. In the bottom left, this is just a pathology post-mortem eye, and you can see all the layers of the retina. And yet with this OCT image, you can see all the exact same layers of the retina as well. In fact, this is an OCT of my own eye that I took undilated. It took about 30 seconds to obtain. And again, you can see every single layer of the retina. I think the most important layers of the retina that we look at is the retinal nerve fiber layer. And these are the axons that give rise to the optic nerve, the retinal nerve fiber layer. Another important layer is the ganglion cell layer. These are the cell bodies that give rise to the optic nerve. And another important layer is the ellipsoid zone or photoreceptor layer. And so OCT allows us to detect optic nerve damage and also allows us to differentiate between optic nerve disease and retina disease where retina disease tends to affect the ellipsoid zone. Optic nerve disease like optic neuritis will cause thinning of the retinal nerve fiber layer and ganglion cell layer over time. And so this OCT is available in pretty much in all eye clinics and is a vital instrument and tool that we use for our patients with optic neuritis and optic neuropathy. This is a standard OCT readout of the optic nerves. And what you're going to see here is the average retinal nerve fiber layer thickness shown here. And a normal thickness is between 80 and 110 microns. It becomes thinner over time, but that's about normal. And this is a normal patient. And what happens with optic neuritis is that the nerve will actually become thin over time. And if the nerve is swollen, the nerve will actually be thick. And what's nice is it's actually color coded, and it's color coded against age matched controls, where green is normal, yellow means it's mildly thin. That means you're 1 to 5% compared to age matched controls. And red means your nerves are too thin. You're less than 1% compared to your age matched peers. And then white is too thick. That means you're thicker than 95% of people your age. Of course, this is compared to a normal distribution. So someone always Eve could be normal and still be in the red. Someone has to be that 1 in 100, or someone might have a colored white retinal nerve fiber layer thickness because it's too thick. Because again, someone has to be in that 96, 98, 99 percentile. But for the most part, the colors are helpful. If it's green, it's going to be normal. If it's red, it's too thin. If it's white, it's too thick. What's nice about OCT is, again, we can quantify that thickness of the nerve, and it can actually be helpful in the acute setting of optic neuritis. We talked about how MOG tends to cause more disc edema than NMO and MS. And so with OCT, we can actually quantify how much thickening there is during acute optic neuritis. And this is just an example of a couple patients with optic neuritis. This is a NMOSD patient with optic neuritis in the left eye, and you can see a thickness of 93 microns, which is actually normal. And this is a patient with MOGAD and optic neuritis in the left eye with an RNFL thickness of 215 microns. So now the nerve is 2 times thicker than normal. And that's very, very thick. Anytime I see an optic neuritis and I see that much swelling, I'm going to think MOG is going to be very, very high on the list. NMO and MS much, much lower on the list. We recently did a very large international collaborative study that was published at that was presented at ECTRIMS, where we compared 75 MOGAD patients with 27 NMO patients with optic neuritis. And what you can see here is, on average, there was much more thickening of that retinal nerve fiber layer compared to NMO. And, MOGAD tends to have much more thickening. And we found that if you had this cutoff of 125 microns, you can see that we're capturing a good amount of the MOG optic neuritis patients and very, very few NMO patients. And so if you have a thickness above 125, you want to have MOG much, much higher in your differential diagnosis, and the likelihood of it being NMO is quite low. And so that's why we can use OCT in the acute setting to kind of help differentiate between the two diseases, especially early on, because it can take 1 to 2 weeks for the antibodies to come back, for the MOG antibodies and the aquaporin 4 antibodies to come back. And again, we talked about how NMO tends to have very, very severe vision loss with poor outcomes. If you've got a patient with a severe optic neuritis and we're not seeing much thickening of the nerve on OCT and the MRI looks like NMO, you might consider early plasma exchange. But if you've got a patient with a thickness of 300, the MRI has pretty profound perineural enhancement of the optic nerve, you might lean more toward MOG and say, I'm going to treat with the steroids and I'll reserve plasma exchange in case it doesn't respond to the steroids. Another thing that OCT helpful for is quantifying the amount of damage after an optic neuritis attack. And so this is the NMOSD patient with acute optic neuritis in the left eye, where again, we're not seeing that thickening. And what we see after optic neuritis, typically 3 to 6 months after optic neuritis, we get pretty significant thinning of the retinal nerve fiber layer and the ganglion cell layer. And this tends to correspond to the visual recovery. If there's more damage, there tends to be worse outcomes. It's certainly not a perfect one-to-one. With optic neuritis, you can actually have pretty significant RNFO ganglion cell loss and still recover to 20/20. But certainly the more thin you have, the less chance of recovery. And when you look at all the studies comparing NMO to MS, essentially what you find is that NMO tends to cause more severe thinning on OCT than MS after optic neuritis. This was a nice study where it compiled all the prior studies in the past. And this is the retinal nerve fiber layer. And this line right here is 0. That means if MS and NMO caught equal amounts of thinning, everything would be right down the middle here at 0. But you can see the vast majority of studies are showing that aquaporin 4 NMO optic neuritis causes more thinning of the retinal nerve fiber layer than MS. And the same thing when we look at the ganglion cell. You can see again, if they had equal amount of thinning, all the studies would be here. But as you can see, they're all shifted to the left, showing that NMO tends to cause much more thinning of that retinal nerve fiber layer and ganglion cell. And that correlates with the poor outcomes after optic neuritis. Another very helpful tool that we have for confirming optic neuritis is an MRI. And with the MRI with NMO, we tend to see longitudinal enhancement of the optic nerve. You can see here that almost the entire optic nerve is lighting up white. And with NMO, it tends to do that. When you get an MRI, it's important to make sure that's an MRI brain, but more importantly for detecting optic neuritis, it's an MRI orbits with contrast. And you want it to be an orbital MRI with fat saturation. That's important because you can see here it's so obvious that there's inflammation of these optic nerves. But if you get an MRI without fat suppression, without contrast, you're not going to see that optic neuritis. And this is a rip-roaring optic neuritis that you're not going to see without that fat saturation. And so again, if you're thinking about optic neuritis, you're getting an MRI brain looking for things like white matter lesions to suggest MS, and an MRI orbits with contrast, and that's how you're going to make your diagnosis. Another thing that NMO likes to do, in addition to causing longitudinal enhancement of the optic nerve, is about 20% of the time it'll actually affect the optic chiasm. And that we almost never see with multiple sclerosis. Sometimes see with MOG, but not as much as NMO. So if you see optic chiasm involvement, you want to think NMO pretty high on your differential diagnosis. And so just a quick summary in terms of how these entities tend to present. With MS, it tends to cause short segments of enhancement, and on the MRI brain, we'll often see these periventricular white matter lesions. With NMO, it causes that profound vision loss, not nearly as much disc-edema as you do with MOG, but it can cause a little bit of disc-edema, likes to affect the chiasm, and of course on the spinal imaging, you often get this longitudinal enhancement of the optic nerve. With MOG, it's the most likely to be bilateral. Again, 50% of MOG optic neuritis is bilateral simultaneous, about 20% of NMO, and only about 3% of MS. MOG, it tends to cause more disc edema, which we can actually quantify with OCT. If you see a lot of RNFO thickening, you want to think about MOG, less likely NMO and MS. And then with MOG, it tends to cause longitudinal enhancement of the optic nerve, similar to NMO, but at about 50% of the time, the enhancement and inflammation is so profound, it'll spill into the orbital fat, which we call perineural enhancement. That's something we don't commonly see with NMO or MS and make you think about MOG. And with MOG, it can cause other areas of inflammation. This is an example of ADEM, another common way that MOGAD can present. So again, these are our three main demyelinating causes of optic neuritis. Any patient with optic neuritis, these have to be on the differential diagnosis. You have to be getting antibodies for aquaporin 4 to look for NMO, antibodies against MOG to look for MOGAD. And so these essentially are the visual sequelae from optic neuritis. Essentially, that's the workup. Now we're going to talk about some of the sequelae from optic neuritis. Before we go into these, though, I do want to talk about how those prior tests are very, very important for confirming optic neuritis. because a patient could potentially have decreased visual acuity or eye pain, but it's not a true relapse. There's potential pseudo relapses that can occur in a patient, especially if they had prior damage to the optic nerve. And so ways to confirm an attack is we essentially want objective evidence. And the objective evidence would be a change in the way the pupil responds to light, a relative apparent pupillary defect, MRI enhancement of the optic nerve, confirming inflammation of the optic nerve, or OCT changes, essentially thickening during the acute attack or thickening that occurs afterwards. And again, it's very, very important to confirm these attacks because it not only manages how we're going to treat in the acute setting, but also how we're going to treat it long term, whether we have to escalate our chronic immunotherapy in some of these patients. And so all the things that we talked about and stepped through in terms of visual acuity, visual fields, pupil exam, OCT, MRI, those are all very, very important to do when you see a patient with optic neuritis. So now what we're going to do is talk about visual sequelae from optic neuritis. And again, the most common one that we talked about is decreased visual acuity. And again, we talked about how we're going to check for visual acuity, and with NMO, that optic neuritis tends to be quite bad. But what's interesting is some patients, less common with NMO, but it can still happen with NMO, is that they can recover back to 20/20. So they're completely normal on the Snellen chart. When they go to the doctor, they're reading this 20/20 line, and yet oftentimes they're saying, I'm 20/20, but I still can't see very well. Well, there's a lot of different reasons why they may not be seeing well, and we're going to step through some of them. One is they may be 20/20, but they're missing a ton of visual field loss. And so, of course, that's going to affect your vision. If you're missing half your vision, even though you're 20/20 in the chart, but you've got just a tiny little island of vision, that's going to cause a lot of visual difficulties. And so, again, we're going to check our visual acuity. We're going to check our visual fields to see if they've got deficits in visual field. But sometimes a patient with optic neuritis, they're 20/20 and we do a visual field and it's completely normal. And they still said, "What? I still can't see as well as before I had my optic neuritis." And I'd say the most common reason for that is actually probably because of decreased contrast. Even though a patient improves to 20/20 with full visual fields, it's very, very common for colors to be washed out and the contrast to be washed out. This is just an example of a patient with more and more diminished contrast. This patient could actually be 20/20. You can still make out, these ripples in the wave here, but things are very, very washed out. And we can actually quantify that with low contrast visual acuity charts. So here's your high contrast visual acuity chart where a person might be able to read the 20/20 line, but with these low contrast visual acuity charts, they're not able to make out nearly as much letters as they could. And that's our way of quantifying it. And so again, this is very, very common after optic neuritis. Even after they recover to 20/20 with full visual fields, that contrast is often diminished. Another thing that patients often have is light sensitivity. This is an interesting finding because you'd think that after optic neuritis, you're losing vision, and so you'd think that the brain is getting less light. The patient should be less light sensitive, but light sensitivity is a very, very common occurrence after optic neuritis. This does tend to improve over time after the initial optic neuritis attack. But patients are sometimes left with permanent light sensitivity. One thing that we can offer our patients is FL41 lenses. These are essentially sunglasses with this FL41 tint. It's this pinkish hue. And this can be used during inside the buildings. It can be used at night because it's not so dark like very dark sunglasses. And it tends to be a filter that blocks the most commonly noxious wavelengths. And so this is something I offer to my patients who have light sensitivity after optic neuritis. It doesn't work for every patient, but it works for a large number of patients. Another thing that patients might complain of is transient blurring of the vision with exercise or heat. and that is called Uthoff's phenomenon. And this is a very common occurrence after optic neuritis. And what's important to note is that this isn't damage to the optic nerve. Essentially, it's just a transient blurring. What happens is the heat actually slows down the speed conduction down the optic nerve, and that's why the vision gets blurred. But it's not actually damaging the optic nerve. I think that's one thing my patients have always wondered about. If, I'm sitting in a sauna and things are getting blurry, am I causing damage to the optic nerve? And it's not. It's just temporary slowing down the signal transduction down that nerve, but it's not going to be permanent damage. And that's something that you can talk to your patients about and just provide some reassurance there. But it's a very common finding in any optic neuritis, even if they recover back to 2020. Another thing that patients might report is that movements seem a little bit different between the two eyes. And there's something called Pulfric phenomenon, which is an interesting phenomenon where essentially um, after optic neuritis, the signal down that affected eye is going to be slower. And if the other eye is unaffected, you've got a fast signal going on. And what ends up happening is that because the speed down the optic nerves are different, if you've got an object kind of swinging back and forth, it'll actually look like it's moving in a circle. And that's called Pulfric phenomenon. And that's a common reason why movement seems a little bit off in these patients with optic neuritis. And just something that we can explain to them that it's normal. Essentially, one eye is getting a relatively slower conduction speed to the visual cortex compared to the other eye. Very, very common feature of optic neuritis, even again, if they recover back to 2020. What we're going to now talk about is, what can we do if they've got low vision? So essentially, if the vision is very poor, a referral to the state services of the blind would be helpful. Every state has services for the blind or visually impaired where they can actually even send personnel to a person's house to make sure that the house is safe for them. And they'll have a lot of other resources for visual impairment. We now have a lot of technology like talking books, talking watches, iPads, where you can magnify things, and that's helpful. Another helpful thing for patients with low vision is a referral to a low vision optometrist. These are optometrists who specialize not in diagnosing the cause of the vision loss, but essentially taking a patient's vision and saying, what can they do to optimize that person's vision? It'll be different depending on how impaired the vision is. If they're 2200, then they may still be able to recommend some magnifiers. If the vision's a certain other degree, they'll have other suggestions, and they'll be up to date on the newest technology. And so here are just some examples of ways of improving vision. It could be just super thick glasses. It could be handheld magnifiers, electronic magnifiers. We talked about the FL41 lenses for light sensitivity. And there's desktop magnifiers, which essentially you put the material below the screen and then it'll magnify it. And there's newer technology as well. And again, your low vision optometrist is going to be aware of these. One is an ultra cane. So it's similar to a cane, but it actually has an ultrasound so that with a cane, you can make sure you're not bumping into things kind of down below where you're putting the cane. But with the ultrasound, it would actually prevent you from bumping into things at eye level. And so that's important. There's other newer technology like OrCam or eSight. These are pretty neat technologies where, for instance, OrCam, if you look at an object and press the button, it will actually kind of read what you're looking at. eSight essentially magnifies the image and can improve on the quality of the image when you're putting these on. And this is just a video of an example of OrCam, which we don't have time to go over, but if you just Google a day in the life with OrCam, it'll actually take you through how it works. Essentially, this person is just going to click and whatever they want to look at, it'll actually read to them what is on that screen. We also have some apps that are being developed. I have no financial interest with any of these companies, but one of them is something called Be My Eyes. This is a pretty neat app where essentially normal volunteers can sign up for this, and then patients with impaired vision can sign up for it. And if a patient essentially will have a camera who's impaired and will call it up, and if a volunteer will actually just tell them what they see. Essentially, they can say, "I'm looking at a laptop. It says Be My Eyes." Essentially, they're talking to them and can tell them and kind of guide them. And so it's Be My Eyes. And here's a video on Be My Eyes. Again, we don't have time to go through it, but if you just Google "Be My Eyes" brings sight to blind and low vision people, it'll kind of step you through how it works. But again, these are ways that technology can improve our vision now. The future is going to be things like cortical visual implants. That's going to be one option, where essentially there's clinical trials ongoing right now, such as one example of this is the Orion visual cortical prosthesis system, where the optic nerves are damaged. So instead of putting a microchip in the eye, essentially you're bypassing everything and putting the microchip in the visual cortex. There's several clinical trials ongoing. The drawback is the vision right now for this is pretty rudimentary. Essentially, you're just trying to be able to see movement or a little bit of some shapes, but the vision's, not great with these. But technology will improve over time. Um, Another thing that you might hear about is electrostimulation for optic nerve damage. One example is the Federal Restore Visions Clinic in Germany. And there's currently some randomized clinical trials for glaucoma, not optic neuritis, but glaucoma, looking at electrical stimulation. I haven't seen huge benefits from this, but at least I know it won't do harm. And so this could possibly, if these clinical trials show that it works, could possibly be a treatment to try and help stimulate optic nerve that have been damaged. But again, haven't seen huge benefits so far, but hopefully the clinical trials will show some benefit. And then I think the biggest one is going to be stem cells. Right now, we can essentially grow optic nerves in a dish. The drawback is we don't know how to make those optic nerve cells grow from the eye to the middle brain, which is its first connection. That will be the future, but we're not quite there yet. And it's important to note that there's actually reports of stem cells being injected in the eye and causing blindness. And so until we have this having better technology, some of these clinical trials proving that it works, I would avoid some of these stem cell clinics that are essentially not covered by insurance. I would avoid those right now. And so this is just a diagram of visual visual rehab in terms of the tools that can be used now and tools that will be used in the future. So in terms of our pros, NMOSD optic neuritis causes blindness. Our vital signs of vision in terms of what we check are visual acuity, color visions, pupil exam, visual fields, OCT, and MRI. But optic neuritis can cause issues beyond just visual acuity that we talked about, and there's a lot of options for visual rehab. Here's a pocket guide that has the tests and examples of ways we can evaluate vision and how we can optimize vision. And so this is a quick pocket guide that you can use as a reference.
John, thank you so much for that excellent presentation on visual health diagnosis and approaches to managing visual issues in patients with NMOSD and related disorders. There are some questions that we have time for. The first, why are visual outcomes so poor with NMOSD optic neuritis?
I think it has to do with the pathophysiology. With NMO, we know that the disease agent is the aquaporin-4 antibody, and essentially it binds to aquaporin-4 and activates complement, and then that cascade leads to astrocytic cell death and then secondary demyelination. So there's actually cell death as one of its root cause through complement. We compare that to MS, which is more of a demyelinating disease, and MOG, which is probably more inflammatory. I think those optic neuritis tend to recover better, but with NMO acting through complement and astrocytic cell death, I think that's why the recovery is so poor. And that's why we have to recognize these patients very early on, treat them with IV corticosteroids and plasma exchange as soon as you recognize this being NMO optic neuritis, because as we talked about, a third of patients end up legally blind.
So, John, that implies that aquaporin 4 and MOG proteins probably a little bit differentially expressed in these different tissues, yeah?
Yeah, differently expressed, one, and then two, just even the pathway once those antibodies bind is completely different.
Yeah.
Again, with, aquaporin 4 just going through complement, MOG probably going more through inflammation.
Excellent. The next question has to do with use of plasma exchange. Would you use early plasma exchange on every patient who has severe optic neuritis?
That's a really good question. A lot of studies have suggested that plasma exchange leads to better outcomes, especially if early. And for those that aren't familiar with plasma exchange, essentially, what with this treatment, essentially you're taking a patient's serum and plasma, and then you have a plasma exchange machine that essentially removes all the pathologic antibodies and cytokines, and then you give back plasma that doesn't have these pathologic antibodies and cytokines. And there's been a lot of retrospective studies suggesting that early plasma exchange leads to better outcomes. The only drawback is if you've got a patient who's coming in within 7 days and they're 2200, a lot of those patients are going to recover even without treatment. And then if you have a patient who's 2200 still at 1 month, that's a selection of patients that are already going to do poorly. And so anytime you have this potential intervention, it's always going to look like early intervention is better because you're selecting a group of patients that a lot of them are already going to do better, whereas later on at 1 month, a lot of those patients are going to do poorly regardless of what you do. And so, when it comes to this, again, if I know they are NMO and they've got severe optic neuritis, I am going to be doing early plasma exchange and IV steroids right off the bat. But otherwise, I'd probably do IV corticosteroids. And then if they don't recover, in a week or so, then I'm going to be adding on plasma exchange. What's great is we actually have a clinical trial that be enrolling starting early fall of this year, where we're going to be randomizing severe optic neuritis, severe transverse myelitis to early plasma exchange and IV steroids or IV steroids alone and a delayed rescue plex at 7 to 14 days. And so this will ultimately answer, does early plex actually help? Do we need it for every severe optic neuritis? It's really that randomized clinical trial that's going to be important. It's called Timely Plex is the name of the clinical trial. So we'll have this answer soon enough. But right now, I would say NMO I would. Otherwise, I'd probably do IV steroids and then use rescue plex if they don't respond.
That's really exciting, John. And are individuals able to access that clinical trial through clinicaltrials.gov or through Mayo Clinic?
Absolutely. It's through clinicaltrials.gov. We're actually going to have 31 sites around the country enrolling for this trial. So it's certainly something that we're really looking forward to, and it's going to provide a lot of meaningful information on early plasma exchange. We're also going to be drawing blood as part of a biorepository, so we're going to learn a lot more about disease biomarkers and potentially even find new biomarkers of disease for some of these idiopathic optic neuritis and transverse myelitis attacks.
Yeah, that sounds really promising. John, you emphasized making clear the difference between a possible relapse and a pseudo relapse and how that's so important for sort of managing next steps. What would you say about best ways to differentiate a true relapse versus a pseudo relapse?
Thanks, Michael. Again, this is a very, very important question because as we talked about, it not only matters in terms of how you're going to treat that attack, but most importantly, how do you go long term? Do you have to escalate immunotherapy? And the drawback is patients will sometimes if they had a prior attack, will sometimes have flares of eye pain, and it's unclear if it's a true attack or a pseudo relapse. And ways of really having objective evidence of it being an attack. If there's blurred vision and vision loss, there should be a relative afferent pupillary defect. At least 90% should have enhancement of the optic nerve. And then on OCT, a good portion will have some RNFL thickening in the acute setting. And the most sensitive way is actually over time. If there's an optic neuritis with vision loss, there is going to be a footprint on OCT where you get that retinal nerve fiber layer and ganglion cell layer thinning. So it's one of these things where we might say, well, maybe that's an optic neuritis and we'll just treat it just in case. But that OCT, 1 to 3 months later, that'll be essentially the arbitrator. Because again, if you have an optic neuritis with vision loss, you're going to have subsequent thinning. So that's probably the best way to confirm an attack.
Great. Thanks a lot, John. The the potential technologies that you mentioned that are possibly going to really be helpful in patients who've lost vision include a number of sort of electrical and mechanical technologies, but as you mentioned, stem cells. And I guess the question really is, is it ready for prime time now, or what would you say about that?
Yeah, I wish it was. Again, we can make stem cells and grow an optic nerve in a dish, but the drawback is that nerve has to go from the eyeball to the middle of the brain, this structure called a lateral geniculate nucleus as its first connection. And we don't know how to make that nerve grow the correct direction right now. And so there are stem cell clinics right now, private practice, that will essentially with paid payments will inject stem cells into the eye. But again, we don't know how to make those stem cells grow to where they're supposed to right now. So I wouldn't right now, especially because there have been reports of patients who developed a lot of inflammation and vision loss and even complete blindness from some of these stem cells. So until we have it working in an animal model and then we have some clinical trials in humans, I would avoid the stem cells right now, despite how tempting it sounds like to get them, because, I can say I have an optic nerve in the dish that I, grew from your skin. Don't you want me to put that in your eye? Again, right now I wouldn't, but it is encouraging that if we get it working in a dish, usually it takes about 10 years to get working in animal. And then after that, it takes about 10 years to get working in a human. I do think the future of vision restoration will be stem cells. It's just not ready for it right now.
That sounds good, John. And then lastly, sort of a humanistic question really has to do with, you know, in a patient who has recently lost vision or become blind. What would you say might be some of the first steps you would recommend for them in terms of managing their life, if you will, their first kind of ways of adapting to the vision loss?
Yeah, I think some of the resources that are very important that we mentioned would be the state services for the blind. I think, again, they're a wonderful resource that can help these patients. And then seeing a low vision optometrist, because they're going to know about the newest and greatest technology that's out there. Again, that's their profession, their career is to kind of stay up to date on that. And the technology is constantly improving in terms of ways we can improve upon the quality of vision and quality of life. And again, it's important to have kind of a infrastructure there, a support system. But again, there are resources between the State Service of Blind, a low vision optometrist. There's just technology that's constantly improving. And again, technology to kind of regrow the optic nerve or to have prosthetic implants into the occipital lobe. Those are coming in the future, but we do have technology now that can definitely take a patient who's blind and improve upon the quality of their life.
Thank you so much, Dr. John Chen, Professor of Ophthalmology and Neurology and the Director of the Neuro-Ophthalmology Fellowship Program at Mayo Clinic, and a world expert on vision loss and vision health and how to manage those conditions in NMOSD and related illnesses. John, thank you so much. for your time and presentation today.
Well, thank you so much for allowing me to present and having a chance to talk with all of you and answer these wonderful questions.
We'd like to remind everybody that continuing medical education activity is available for this presentation and others. Please visit the GJCF Education Center using the QR code shown here. Select the session you'd like to view and register. View the session to fulfill CME credit and then receive CME certification online. We would like to remind everyone that the NMOSD Grand Rounds series is available for viewing. The next presentation will be by Dr. Ira Lesser, focused on addressing mental health, diagnosis and interventions in patients with NMOSD and related conditions. The GJCF Education Center provides access to the NMOSD Grand Rounds series, as well as other educational events, presentations, and media. You can access the Education Center using the QR code shown here, and we encourage all who are interested to do so. We are greatly appreciative for support for the NMOSD Grand Rounds series, including educational funding provided by Alexion and AstraZeneca Rare Diseases, and educational funding provided by Amgen. We very much appreciate their support.